Start. Oh, there you
go. Good Friday morning.
go.
Thank you for joining us. We'll get started in just a second here. And BJ Claritza, if you want to intro yourselves to start while people are getting into the Zoom room, that might make sense.
Okay. Yeah. Okay. Hi, everybody. Welcome. Most of you guys have probably been here before, and you would probably recognize Dr. Claritza Rios, a friend and colleague for many years, who's done these with us before. So Claritza is back today to talk about one of her hats that she wears. Claritza is a dynamo, one-woman medical stew, internist, ER doc, palliative care doc. And those are just three of her hats. So today we are going to be playing around with conversation about the ER, what it's like to move through the ER and how to make sense of the ER. It's one way or another, whatever your feelings about medicine, however healthy you may be, most of us will find ourselves in the ER at some point. And it's a place of great consequence. Lots happens in there. So I'm going to try to demystify that today. So, Claritza, anything more to add before we get started from your point of view?
No, that sounds like, yeah, let's jump in.
Okay. Well, thanks for being here, my friend. I love doing these with you. So, but one more little reminder, folks, that this is the way these work. If you're new to them, is Claritza and I will go through some slides, level set, kind of set the stage. And then it's the fun part of conversation, Q&A, comments, whatever. But just a little statement here that this is really meant to be very much a safe place. So, to ask questions, to share thoughts, emotions. Even when we're kind of playfully talking about something like the ER, we know that there are lots of things happen in ERs, including trauma and scary things. And there may be bringing things up from your own past. So if we feel a little light or there's some levity happening when something that's actually pretty hard for you to hear, our apologies in advance. We'll try to kind of do the subject, honor the subject and all that happens with it. But do know that you're welcome here no matter what your point of view, and please chime in as you like. And on that note, let's kick it back to you, Sonia, for some of the logistics there.
BJ, and thanks everyone for being here. So like BJ mentioned, he and Claritza are going to go through some slides, and then after that, we will head to you for questions and comments and observations, and you can do that in two ways. You can click the raise hand button, and you can speak with Claritza and BJ out loud, and if you'd prefer to not do that, you can type your question into the Q&A section, and I will read it aloud for you. The chat is also open, so if you have any thoughts that you want to just add in there, please feel free, and thank you again for being here.
Okay, thank you, Sonia. And by the way, folks at home, you may never see Sonia. She rarely shows her mug, but we have many things to thank Sonia for. Of the 8 zillion things she does, she also finds the art for these slides. So if you like the art, put that on your list of things to thank Sonia for. Okay, folks. So, Claritza, culture of places. Big deal.
Yeah.
Can you help us understand what the heck the culture of the ER is?
Yeah, so I think to understand the culture of the ER, it's really helpful to kind of get in the head of the doctors and other providers that work there, right? And I think of emergency medicine folks and the emergency department itself as a group of folks, a team that is constantly thinking of worst case scenario when they see somebody with a particular complaint. What is the worst possible thing that could be happening to this human being? And what's the most common thing that could possibly be happening to this human being with this particular complaint? And so right there, one can imagine, yikes, right? That is quite the challenge for someone. And this is not to oh, take pity on the ER folks, not at all, but it's just to show you kind of the vibe and the energy that is in the room. So I need to rule out, that is cross off things off of a list that we call a differential diagnosis. What are the possible things that this person presenting in front of me can have causing the symptoms? I have to make this list and then rule out, cross off things of that list. So I have to think of the worst thing and the most common thing, and I have to do that in a very time sensitive way because the place is full, packed. Time is of the essence when we're trying to rule out really serious things or we're trying to treat serious things. And so with all that happening, and trying to be nice and kind and work as a team and take care of our own bodies and our own hearts and minds, right? You go to work and you're, probably stuck in traffic or had a, didn't eat breakfast or had your pants don't fit right or whatever. You're also bringing that to the mix. And so all those things together kind of create the energy in the room. I think in addition to that, we as emergency medicine folks and emergency medicine doctors understand that everybody in the emergency room at that time is having the worst day ever. Whether you stubbed your toe and your pain tolerance is whatever, or if you're having a major stroke, or you're coming to the emergency room to have your symptoms managed as you are progressing in your illness, everybody's having the worst day ever. And so we are tasked and privileged to help navigate that with everybody, but also have to figure out who comes first, right? With the mindset of time is of the essence, and the sickest person is prioritized or gets seen first.
Mhm.
That's a lot of words.
But it's great, super helpful, because these are not intuitive places. Kind of like a lot of things in house, we're sort of barricaded from the natural world, not part of it. And so and the rules, however, you might find rules and regulations to kind of help guide you. But this culture, this sort of mindset that you're pointing to, Claritza, has a lot to do with what it feels like to move through the ER. And I just we'll come back to this sort of triage mentality and why it's so hard to be admitted to a hospital sometimes. And how the ER can feel unfriendly in all sorts of ways, like wanting to get you out of the ER. We'll talk about that. But that rule out thing is a really important thing for folks to understand. First of all, medicine, of course, doesn't know everything. But the main job in this acute care setting is to make sure it's not these bad things. So very often people have this very unsatisfying experience where they leave the place not knowing what's wrong or not feeling much better. And can be very disappointing. But what may have happened, and sort of unbeknownst to the patient, is a bunch of hard things were ruled out. So whatever's going on to make you feel nauseated right now, we know it's not cancer, or we know it's not X, Y, or Z. And that is much of the job of the ER, is to rule out the bad stuff, not necessarily always get to an answer. And that feels importantly different. So, all right, we'll keep on chucking here. So, wait a second, let me move my little thing here. Yeah. So ER, lots of cool things, amazing things happen there. It can be saved in an ER, but why is there so much? Is it just laziness and we want people to avoid the ER? Or what? Can you help us understand why we would ever want you to avoid the place?
Yeah. So, and again, everything we're saying here is sort of with our experience, and every human being is unique, and of course, we always want people to follow their gut, follow their provider's recommendations. But as we mentioned, the ER is a fast-paced place. The lights are on 24/7. There is such an effort made to make it a welcoming and warm and fuzzy experience, but by virtue of it being so fast-paced and things moving so quickly, it is very loud. There's alarms going on at all times that are letting us know about different things going on for our patients. And it is just not the warmest and fuzziest place. You're not on a bed, you're in a stretcher. Stretchers are notoriously uncomfortable. And the temperature needs to be maintained in a certain way, and people are cramped together. So the physical space is definitely not super comfortable. I think that the other thing that we touched on in the previous slide is really true here. It's what's a priority. And so a lot of times things that are super important to folks seem to be dismissed because we're busy managing somebody having an acute stroke or a loss of limb or a heart attack, or we're doing CPR on someone, and maybe there's a delay on getting a medication. And so if there's a way in which we can have a symptom managed, a workup done, a diagnosis made in a much more warm and fuzzy place, then we definitely want to advocate for that. Certainly with chronic illness or advanced serious illness, as symptoms become really burdensome, time is precious, right? And making sure that symptoms are managed quickly and that we're looking at the whole person is really important. And the ER sometimes can't really do that when all these other things are happening. And the tough thing about it is that I'd love to say, you know, Mondays at 7 a.m. is fantastic time to go to the ED, but that's not always the case. And so whether it's 2 in the morning or 2 in the afternoon, that, again, vibe, energy will always exist in the ED. And I think, BJ, you want to talk to that, and we can talk about context in a second?
Well, sure. I mean, just to build on that a little bit, like, well, one of the things that's of note is most ERs are relatively impacted. There's a lot going on. They are a very busy place. So if there are things that can be handled as an outpatient or elsewhere, that's usually the way it would be. You know, they're meant to be. The E is for emergency. And by the way, ER, we would talk about ER, that's more common. You also see ED, which is emergency department. Just they're synonymous. ER, ED, same thing. But back to this point, like, you know, one thing, there's a big social thing to appreciate here too, which is, you know, because primary care has been more and more difficult to access in healthcare, because we live with more increasingly complicated situations, social and medical situations, because perhaps of a decline or people spiritual homes, fewer people have churches that they go and talk, you know, get a meal or talk or think something through or get help. You take all these forces away, people don't live near each other, so they're separated from family. All the sort of systems that used to help soak up or take up or hold illness or big life challenges, it's sort of like the ER has become our current church, our hospital, of course, our family. So ERs are filled with people who are there for not strictly medical reasons. And this is a fault of the healthcare. Healthcare is trying to separate social from medical reasons. But what we're coming to acknowledge is you can't really separate those. So ERs are packed with people with issues that are real and pressing and profound. It's just we understand there's nowhere else to turn but the ER. The ER is also not equipped to handle so many issues that present there. So it's a real mismatch, and it is sort of, in this way, it's this catch-all. And the way it's wired, we can't turn people away from emergency rooms, whether they're insured or not, for good reason. That would be immoral. But consequently, another force that just makes ER a place where everyone comes for all sorts of reasons, often not necessarily medical or acute, and can't really be handled there. Am I saying that correctly, Claritza? Does that mirror your
100%. And I think what becomes problematic is that one could imagine that if a doctor or provider or nurse is not giving you the attention that you feel, I have an emergency right now, it deserves, it can sort of vilify that team at that time, and it totally is understandable, but it's a systems issue, right? If I am managing You know, the 88-year-old person with dementia who like was found wandering and has a little bit of hypothermia, and then somebody who got shot in the chest, and then somebody who is doesn't have a place to stay for the night and is having a minor medical issue. All these things are happening at the same time, and while there is a multidisciplinary team on site, there is not enough resources to be able to plug all those people in and also manage everybody with the, you know, we try so hard. And I think if you spoke to any emergency medicine doc, nurse, etc., part of the reason we're so attracted to emergency medicine is because you feel like you're making an impact in real time. And it aches to not be able to do that 100% for everybody you see at whatever level of emergency that you as a person assessing see, but you want to give people attention. You want to give people 100%, and you're having to step back and say, right now, that is in the big picture much more important. And so I need to attend to that. And so avoiding that environment is really helpful. And, you know, from a service standpoint and from like a community standpoint, if you can call your doctor and or call your significant other's doctor, or whoever you're caring for's doctor, and arrange things, you're also doing a service to the community, because that's one less issue that needs to be addressed in this high pressure environment, so that gunshot wound, that heart attack is being managed with the attention that it deserves. And I know that sounds kind of unfair because the system should do it for us, but we know that's not how it works.
Yeah, and the system is inadequate right now. I mean, it really, it should work. We should be able to reach out to our primary care doc. It's also true that it's very hard to find a primary care doc. Very
Yeah.
hard to find a primary care doc who's not overwhelmed in their own workload. So there's so many,
So many.
lots of sort of trying to look at sort of root cause analyze this is pretty difficult.
Yeah.
And you will feel that.
Yeah.
So yeah, well, all right. This will be a thread let's keep
Yeah.
on moving.
And the piece about the no context, I think, is important, you know, as we move through illness. You know, sometimes there's information, important things like that CAT scan that was done 8 months ago, or that diagnosis that I got that impacts this diagnosis. Sometimes in the emergency department, depending on the connectivity of medical records, the conversations had with clinicians, I may not have the context. And so as much training as I have, as much digging as I do, when somebody comes to see me in the emergency room, there is going to be information that is lost, that maybe somebody that knows you for 10, 20 years, they may have that nuance, that stuff they have to know that makes you you. And so that I think is also important to note, that it's in my records. It may not always be in your records, especially if you're going from one hospital system to another, or you're traveling, etc.
Right. So consequently, like kind of moving into okay, so you can't avoid the ER when possible. Sometimes it's not going to be possible.
Yeah.
So kind of cutting to how, okay, we're entering this wacky, wild world of the ER. So how to how to optimize that experience. To your point here, one would be bringing your medical, making sure you or whoever's with you can articulate your medical issues, bringing the medications. If you have a list, great. But if you're in a rush, just take all the meds, put them in a bag, and just get your butt to the ER. That could be super helpful and really important. And to your point, Claritza, a lot of health systems, their electronic medical records don't talk to each other. So yeah, someone probably has their med list somewhere, but it may not be accessible to the ER doc. So hence, bring it with you.
Absolutely. And I think also folks who are on newer medications, folks who are on biologics, folks who are on a novel chemotherapy, this information, understanding, giving us the name of the medication is really helpful, because then if you come in with a fever, or if you're having some complication from it, then we can quickly investigate and be able to to treat the problem. The other thing that I think is really important is that the United States has a war with opiates, right? That, you know, we can talk about the why till we're blue in the face, but with that, there's a culture shift about pain medication. And so certainly if any of the medications that you're on are pain medications, it's really important that we understand that you either bring them or have a list of what the medications are, how and when you take them, especially if you're coming to the emergency room with a pain crisis. Super helpful to us. You know, even as a palliative care doctor, with my palliative care hat in the emergency department, dosing very high doses of opiates is always this, people look at you in a certain way, and it's cultural, it's experience. We just don't have a ton of time where we're dosing these medications. And so having them with you is always really, really helpful.
Right on. Okay, and any other information that you would need the ER team to know? Meds, sure. Medical problem list, sure. Any of your situation, just can't presume that they're going to know. There
Yes,
often
and
people
know
in
us.
the ER, you may not be. Sorry.
No, sorry, you go. Sorry, I thought you were done.
I'm just saying, you know, we're talking as though, you know, you're thinking clearly and calm and can prepare to go to the ER. Sometimes you can't. Obviously, these are true emergencies, 911. Sometimes you're out of it. But so the notes, when possible, you know, and also to a loved one who might be accompanying you, when possible. Right?
Yeah. And this is something that then somebody can go and look up later, but this is super helpful information. Noah wrote something really helpful. I think I hope I pronounced the name properly, which was supplements and over the counters too, and that is 100% correct. You'd be surprised how often there's interactions, and we love to know this because the toxicology of this medications will have impact on how you present to the emergency department. So great point.
Okay. So we said notes on sort of avoiding a place, but when is it in other words, when it's sort of the wrong place potentially, or just an unfriendly place in some level. So when is the ER a right place?
So certainly, if you think you're having a medical emergency, the ER is the right place, right? And so we don't want to deter that ever, right? You know, I think it's also really helpful as you're getting treatment, especially folks on chronic treatment, undergoing treatment that may affect their immune system, et cetera, to really have some rules of engagement and or a list of, if doc, I go to the ER if my temperature is above this, or if I have shortness of breath, or whatever. I think it's also helpful to speak to your provider, doctor, oncologist, nephrologist about what are the non-negotiables. Red light, I have to go to the ED immediately. That's super helpful. But I think in general, anything that is keeping you from engaging your activities of daily living that is causing a lot of burden and we don't have an answer for, a sudden, certainly would make sense for us to see you in the emergency department, especially if it's something all of a sudden. So things like shortness of breath, chest pain, really difficult to control pain, anytime that you have signs or symptoms of stroke, whether it's inability to create, to speak and get words out, you're having numbness, tingling, weakness to one side of your body. Those are definitely concerning signs. And anytime that you can't keep food down, you can't keep drink down, it would be a concern for me, especially in folks that are managing chronic illness. But again, we don't want to deter people from the ED. Your emergency is your emergency. But I think these are helpful in sort of figuring out where I'm at.
Yeah, that I want to draw attention to that. that sudden thing. It's kind of a, I remember working ER and, if someone came in presenting difficult pain or something not easy. And you say, well, how long have you been feeling this way? Oh, a couple months. But it's like, oh, you know, is that an emergency? Why tonight? Why are you here now? And very often the answer can be something like, it's again, there's all these systems issues in the background. We don't have to beat that uh, dead horse. Excuse that. Sounds like a terrible analogy, but yeah, that can be a little bit of a tell. If you need to
Yeah.
go, you need to go. But that what you're particularly keying into is something a relatively sudden change in your status, not a chronic issue that you just haven't been dealing with or someone hasn't been dealing with.
Yeah. And I think also you have to trust your body. If you're starting to not feel well, and you got to think about your situation, who's around. I know people worry about cost and those things. So
Mhm.
we want to validate that all those things are real and they're important, and we weigh them as human beings. We got to weigh them all, right? Because we live in a society where not being able to pay for stuff is problematic, right? So I do
Mm.
want to call that out. But I think if you're starting to have abdominal pain, for example, and it's feeling like it may be escalating, calling the advice nurse for your insurance, or calling the advice nurse at the practice, or calling the practice to say, hey, this is happening. When is it non-negotiable is a really reasonable thing to do. And doing that during office hours is really helpful. People can fit you in. You can come in and see your provider or your doctor. That can be helpful, but just listen to your body and just say, okay, is this getting better? Is this getting worse? Do I have a plan of action? Plans of actions are really helpful. And, in some of the jobs, in a recent job that I had, we build out plans of action for a lot of chronic symptoms. And I love the idea of sort of green light, yellow light, and red light. And we do this for a pulmonary disease, like emphysema and COPD, where people that have daily symptoms, or people with chronic medical problems, that we can say, what is green for me? Green for me is, having no pain or breathing okay. Yellow, I'm starting to feel X, Y, and Z. What would I do then? And it can be an official action plan, or you can make one with your provider. And then when is the red? When do I call 911? Or when do I call the advice nurse? When do I call 911? That can be really helpful as you're managing a chronic illness. And that way when the ER is the right place. But when in doubt,
Mm.
we're always there 24/7.
Can I interject a question
Right.
that's related to what you guys are covering right now? Someone said, is there
Yeah,
a short checklist that I can make that confirms going to the ED is better than urgent care? So I know that I'll be seen in a timely manner versus 8-hour wait time. Like, Claritza, you were kind of checking off things on your finger earlier. Thoughts
Mm.
on something to kind of check down? Is it new? Is it ongoing?
yeah. I mean, I think anything where it's, and this is a hard one, right? Because uh, for me, it's like I have to see you to know, right? When in doubt, the emergency department. But I think in general, anything that is debilitating or impeding your ability to engage in activities of daily living to the effect where you can't even think straight, the emergency room is probably the right place. If you're walking, I think urgent care is the kind of place where you go when I stub my toe, or I'm walking, but did I fracture it? I have a cough, but I'm breathing okay, and I'm engaging in activities of daily living. Maybe that would be the primary doctor's office, actually. But it's a nuisance as opposed to something that is really debilitating or taking away from your ability to engage, whether it's something like, I sit around and watch TV all day. Cool. Like, if you can't even do that, then that's concerning. Or I can't drive, it's so bad. Certainly call 911 there. I can't work because of pain, shortness of breath, etc. That is really concerning. But I think without And I also think it depends on the complaint, right? Like, for me, having shortness of breath with my asthma, there are certain things that I probably as an asthmatic will be able to do that somebody who just had shortness of breath out of nowhere wouldn't be able to do. And so that it's a tough question to answer, but I think anything that is debilitating, anything that keeps you from your activities of daily living would merit a higher level of care. So the emergency department. That was,
And
again,
that
a
last
lot,
point
but
you
it's a
said,
non-answer.
well, these are hard. I mean, you can't, this stuff kind of bucks the checklist mentality. Checklists are helpful, but we can't, every situation can't be accounted for in the checklist. So it's useful to kind of think through, but there's also just the gut sense that something is very wrong, even if you can't even point to it. I would still say, default to the ER. But you said something also really important there, Claritza, which is, if this is an acute on chronic, like you have asthma and you're having an acute shortness of breath episode, well, acute shortness of breath, usually a pretty good reason to go ER. But in the setting of asthma, have you tried the things that normally help? Have you used your inhaler? Are you on your meds? And I would suggest in that setting, try those things first before going to the ER. So in other words, if we said new shortness of breath, decontextualize and be misleading. But to your point, if you have this issue in your life already, try the basic things first. And if those aren't working, then it's a good time to think about the ER.
Yeah.
So, okay. All right. Shall we keep on moving, girl?
Yeah.
Okay. Yeah, we talked a little bit about triage. Let's define triage for folks? It's an important thing that happens in the ER.
So triage is the process in which we provide, usually a nurse will look at your complaint, your medical history, your vital signs, and kind of the demographics your demographics, and say, based on this algorithm that has been determined, a lot of its components are evidence-based, we're assigning you a triage level. And based on that level, you are put on a list that of how quickly you should be seen, basically. And so it literally is a way of us saying who gets seen first. And so different ERs use different triage numbering systems. The Emergency Severity Index, ESI, is a very common one, where one would be somebody, I got shot in the chest and my blood pressure is non-palpable and I am dying. And 5 would be, my cat scratched me 3 weeks ago and it was red and now I picked the scab and it's bleeding a little bit. I don't know why I made that super long story, but you get it, like not as sick. So basically we use a grading system, and based on that, people get seen in different ways and at different times. And so that's really important because sometimes you'll be waiting in the waiting room and your stomach hurts or you're holding pressure on a wound and somebody came in and they're getting seen super quickly and you're like, but what's going on? The other thing that happens in the ER when you're in the waiting room is that you feel like nothing's happening. Why are people, and you see people talking, people walking by, but you don't see any movement. What we don't know is what's going on in the ambulance bay, which is behind the emergency room. It's usually not not visible to most folks. Ambulances may be coming in, and those folks usually have, a real kind of higher triage level, and the team and doctors and nurses may be really busy with that. And you're like, but I'm sitting here and nothing's happened and nobody's moved in a couple of hours because we don't know what's going on in the back in the ambulance bay. And so it's something to think about. And so the timing of when you get seen is based on the triage level.
Yeah. Yeah. Oh, did I just cut you off? Sorry. Oh, yeah. Okay, good. Well, I was just going to say a couple thoughts on that triage thing. So it's really, really key. And remember, like, as Claritza said, as you said, this may be the worst day in your life. And what might seem like feel pretty casual to the ER team who have seen all sorts of things. But remember, the lens that they're looking at here is it a medical emergency? Is there something that we can actually do about it here? So the triage, the order is really based on not the magnitude of your struggle or how miserable you are or how desperate you may feel. It's really the triage is something a little bit more objective than that. Is there a medical problem that we can do something about here? Those are the things that are going to rise to the top. So they're measuring medical insights, not your subjective experience per se. Is one thought. Another thought is probably, chest pain or I fell and hit my head. These are pretty classic. Oh, I gotta see you. You just don't want to miss a heart attack. You don't want to miss a brain bleed. But I would not suggest to you listeners that you try to game the triage nurse with pretending to have issues like a chest pain when you don't. The triage nurses, the triage team have seen a lot and usually will get figured out. And then you're really at the back of the line. So I would not try to game it. I would just try to be very clear about what you are experiencing and let them do their job. All right. Shall we keep on checking?
Yeah. Yeah. And
All right.
I want to make sure that what to expect, the next steps, depending on the situation, the possible outcomes is we treat you and we're able to resolve the problem and we can send you off into your life again and you're free, with follow-up, making sure that there's either further investigation or that whatever issue gave you the symptom, that it's being addressed. Then there's a possibility that you get admitted. We have a diagnosis, or we kind of are close to a diagnosis, or maybe you need IV fluids, or maybe you need antibiotics. We need to dig more. Then you could be admitted, and there's a couple of options there. You could be admitted to a medical floor. We call them med surg floors. You can go into an observation unit, which is you have something and we don't feel comfortable with you going home, but you don't need to be 100% admitted. So that's like maybe 24 hours, 48 hours that you'll be in the emergency department, in the hospital, and then you can go home. And that also has to do with some insurance and how hospitals get reimbursed. And then another option is that you would go into the intensive care unit, where symptoms are really severe or your condition is severe enough in which you need intensive care, meaning one-on-one nursing, a lot of monitoring, a lot of treatment. So those are the things that you can see happen.
Right on. And remember, they're going to try to send you home if this could be handled as an outpatient. So
Absolutely.
let that be good news. But oftentimes you'll want to be admitted,
Yeah.
and it just may not happen.
Yeah, and I think that's an important thing. Why do we want to take people out of the hospital? It behooves hospitals to have beds full, right? So if we're worried about finances or something like that, like the hospitals want people in the beds. But what do we know? What have we learned from hospitalizations that weren't indicated? That we can do more harm. The hospital, as much as they get wiped down and as much as people wear gloves, they're not the best place for people in general. And so, of course, we want to admit people when it's appropriate, but we also know that it doesn't come without any risk. There's risk, right, of iatrogenic infections, meaning infections that happen in the medical setting or due to medical interventions. And so we want to send people home as much as possible. I had a rule in the emergency department. Anybody over a certain age, I didn't, no matter what I had to do, any older folks, I had to make every effort to get them out of the hospital because they're more likely to get delirium, meaning have a loss of sort of their ability to engage in the here and now. They're more likely to get infections. they're more likely to lose muscle mass because they're laying around a lot in the emergency room or the hospital, and they're not getting the movement that they would get in their usual environment. And so we want to keep folks, but we also understand that it comes with risk. And so we want to do it only if we have to. Sorry, that went on and on.
No, it's all right. It's important stuff. Okay, we'll keep on moving here. There's some just like kind of this one I think would be pretty quick, sort of just tactically how to make a pretty inhospitable environment a little bit more friendly. Because if you do end up in the ER, it's pretty likely you're going to be there for quite a while.
Yeah. So
many hour
besides
waits
these,
sometimes, etc.
totally. So phone charger or like one of those battery packs, even better, because then you're not dependent on finding a plug, and you certainly don't want to unplug anything in the emergency department. They're plugged in for a reason, please. Your med list, of course, pillows, earplugs, eye masks. If these things bring you comfort and make you feel safe, bring them. Plushie, plushie. I'm such a mom. Whatever it is that brings you comfort. Blankets. The ER sometimes can be quite cold, and so these things can be helpful as well. And certainly, if you're receiving any feeding that is, if you have any artificial nutrition that is very particular, then you certainly would want to bring that in, or any infusion that is rare that needs to happen at 2 o'clock every day. You want to make sure that you bring that in as well.
Oh, some other ones: hearing aids, dentures. Oh, big ones. Eyeglasses. So that you can optimize your ability to communicate with those around you.
100%.
Very important.
And it has to stay in your person. As things get put in bags, great, things are labeled. But I will tell you that in my experience as a ER doc and then as a hospitalist upstairs, people lose stuff. People lose stuff. So the dentures, they have to be in your body or give them to a family member. Your glasses on your person. Very important. Things get lost because, again, there's so much happening and so much moving. And infection control is something that also we want to be really mindful in the ED. So when in doubt, things can get thrown away. And so pretty please keep that stuff on your body.
Right.
But that's a good one. The hearing aid, especially, really important.
Yeah, it's a big one because maybe obvious reasons. Okay. Yeah, what's this shared decision making stuff, Mama?
So I think it's really important as we're talking about, all the things that are coming from the ED. We want to also make sure you understand that you're entitled to ask questions. You're entitled to have answers. You're entitled to say, what are you putting in my body? You're entitled to say, how long is that going to take? What is that? Why are you taking blood from me? What is the differential diagnosis? How did you rule that out? I want you to understand where people are coming from, but it doesn't mean that you are not allowed to do all those things. If we don't do it naturally, then you can ask, because that is your right. So that's important. Shared decision making, wanted to put this slide in because I think it's important that people understand that you go to the emergency department, whether your oncologist sends you in or you're having symptoms, you are going to see an expert in emergencies. This expertise is valuable. And so sometimes somebody will come in and be like, my primary doctor said to get an MRI. And I'd be like, oh, bless everyone. Oh, that's so lovely. And, of course, the primary doctor knows a ton, and we love working with primary doctors. And if in my examination I see something that maybe is an answer, or I see something that is indicating, or maybe an MRI is not the first test that I would go for, but maybe the second test, then that expertise has value. And whether it's calling your primary doctor or having a conversation with you, that kind of triangular communication is really helpful, I think. But with all of that said, the key thing with shared decision making is understanding that you want to work together with all these people that are on the team that day, whether it's your primary doctor, the emergency medicine doctor, and you, in making decisions about what tests to get, what medications to take, whether you should be admitted or not admitted, that all these decisions are made with you. That we're educating you on risk, benefits, potential outcomes, and that you, based on your preferences, on your values, and your goals, that we're coming up with a plan together. And I think sometimes we get caught up in sort of the medical legal piece of it, of like, you have to be admitted because if something were to happen to you, you need to sign your life away or whatever, all these things that kind of can be kind of icky when you're having those interactions. But I really want to encourage these conversations with folks and just speaking to, based on the fact that I want to be able to go to my granddaughter's graduation on Friday, Doc, and I have, let's say, diverticulitis, like inflammation of the gut, an infection in the gut. Usually, depending on how somebody would present, I would admit that person to the hospital if they have a really tender belly and other indications. So I would have a conversation with someone and say, understand their preference and say, okay, I understand that you want to go in the graduation with your granddaughter, but these are the potential outcomes. These are the things that I'm worried about. And these are the alternatives. With the alternatives, they could be great. They could not be great. This is, and we would talk about that. And then together we would come up with a plan so that you're, understanding the risk and the benefits, but that also your life, you understand how it would impact your life on Friday, right? Missing the graduation, but also after that. And so coming together and making decisions on everything having to do with your healthcare together as a team. That I think is really important.
Yeah, I'm sorry to interrupt you again, Claritza. Yes, amen. I mean, this is the way it really should work throughout healthcare. And this is one of the reasons why we always want you to, kind of cut to this next slide too about, this is our last slide, about advocacy. You got to stay engaged with your healthcare versus just handing yourself over as a general rule. We want to advocate for that up and down. These are decisions you make together with your doctor and your family and friends, et cetera. And practically speaking, especially in an ER, you may be out of it, not able to communicate much, or
Right.
things may be going so fast that the informed consent conversation happens in 5 seconds. And so acknowledging that these are supposed to happen and a medical team is meant to be encouraging this kind of decision making together. That's all true. And we want you as patients and family members to do likewise. It is also true that these environments are crazy and things are going wild and very quick. So you might need to put your hand up and say, hey, can you repeat that for me? I didn't understand why we're doing this, or I need to talk to you about this or that thing. So again, this sort of, and it's hard to do when you're sick, Lord knows, in the middle of an emergency. So these are aspirational. These are where we want to encourage you, and also to acknowledge that sometimes these things just can't happen. But wherever possible, you or your family member are taking an advocacy role. The system is not malignant per se, but it may struggle to acknowledge you and what's going on, and it may homogenize you, and it may blow past a lot of your opinions or your idiosyncrasies, et cetera. So staying involved, staying engaged, and putting your hand up and making yourself known versus waiting for them to ask is also good advice, I think.
I think
what
that
else to say here? Yeah.
I think self-advocacy, along with like the reality of the place you're in, bringing those things together is really important, right? So asking questions. In the emergency room, we err on the side of more. This is the United States. You've heard about all the things that happened and the medical legal burdens on healthcare providers. When somebody comes to the emergency room, my job is to keep them alive. To think of the worst possible scenario and to have a big list of differential diagnosis, and then be it by looking at you, by touching you, by looking at your vital signs, ruling them out. And I don't always have to do a big test to rule out the scary stuff, but my job is to do more. And so if you want to engage in some discovery or you want to engage in some symptom management, but you don't want to engage in workup, as long as you understand the risk that comes with that, we would honor that. But I think it's important for people to know that the common sense of, this person doesn't look like they want to be here for 13 hours we don't come into the conversation with that mindset. We come in with the conversation with, I'm going to do everything in my power to keep this person alive. And so as much as possible, especially as chronic illness evolves, and especially folks closer to the end of their life, time is precious, and we may not want to be investigating and doing all these things. So having things like a pulse, doing the thought exercise of, if this happens, what would be okay and not okay for me to do, so that your family members or other people advocating for you are able to speak to that, would make it much easier, because we'll always err on the side of more. And I think that's changing, but just culturally, that's the way the ED works.
And when you say more, you mean more intensive care, more invasive care, more
Thank you.
testing, more
Thank you for that
interrupting
clarification.
nature. Yeah.
100%.
Yeah.
So I would
Yeah.
want to, I want to know what's going on down to, what cells being affected, right? And so that means tests. I want to do more aggressive treatment. We do everything to prolong life, and not always whether or not that makes sense or honors the person in front of us.
And prolonged life in the medical sense is continue having a pulse. This is not talking about quality of life. This is where, to your point, Claritza, you got to be the advocate of what you consider life, quality of life. The medical system is going to reduce life to, do you have a pulse, essentially? Not in a cruel way, but sort of in a measurable way.
Yeah.
So, yeah. Okay. All right, my friend. Woo, that was fun. That was a whirlwind. There's a lot in there. Yeah. So, folks, why don't we open this up to questions and comments now? And I'm gonna step out for 1 minute. So I'm gonna put this on mute. But Claritza and Sonia, please take it away. I'll be right back.
Yeah. Let's see, we had a few questions that came in while you were speaking. The first one was, when there is a doctor shift change, how much information is passed on to the next doctor who comes on?
Yeah, so we call it sign out or endorsement. And yes, there's a lot of information that gets passed over to your colleague. So we present all the cases, and yes, there may be some nuance that is missed. And so it is really reasonable to think and consider presenting, letting people know again, I am here for this, and that. I think it is a reasonable thing to do. But yes, we do endorse the plan, who you are, why you're here, and then what we are thinking to the next doctor.
Great, thank you. Next person said, I'm wondering if there is a person in the ER other than the doctors or nurses that a patient or family member can request specifically for help on the advocacy piece.
Yeah. So patient care services, patient advocate, depending on the in the setting that you're at, there is an office where the role of those folks are to advocate for folks and to help with the patient relations. And in many places it's called patient relations. And you can certainly ask the front desk folks for it. Sometimes a social worker can be really helpful if you're having, if you're, need a little extra support. So absolutely. Patient relations, patient advocate, social work, and the nurse front desk can be really helpful in that. And sometimes I tell, as a doc, we can also advocate for that.
Great. Okay, next question. My question is procedural and accurate as of this morning. My 88-year-old dad is in the ER with stroke symptoms, and my 83-year-old mom is partially deaf and has childhood trauma from a hospital experience. Their adult children live hours away. What are the available and best options to have dad's up-to-date, accurate information available to our family?
So a couple of things. I'm so sorry you're having to do this from far away. So incredibly hard. We love family members. So we love to be able to have a point person. So your mom, if you think it's helpful, your mom can, and if you're that person, just say, Mom, anybody comes to talk to dad or about that, just say, please call my child. And make sure that that name is added to the chart, that the contact information is put in for any things where you feel like there's a consent that needs to be given and you want to be notified. Obviously, if your dad is able to make medical decisions, that obviously they would be the person to make them. But if you feel like between the three of you, you come up with a plan of saying like, this really should be our trifecta, or, however many kids should participate in supporting this shared decision making, then that phone number should be in the chart. And we love that because it also helps us kind of understand, like, if dad is unable to communicate or if mom is overwhelmed, how we can present the information in a way that makes the most sense.
Great. Okay, this one's got a little bit of a lead up and then a question within it. As an
Sure.
advanced lung cancer patient going into my 4th year of treatment, I've had one trip to the ER where my oncologist met me and helped me avoid a hospital admission. I do not want to be hospitalized at the end of life, but the bias is to turn to the ER when things are unmanaged.
Sure.
What are the alternatives to ER in terms of getting help in one's home? Are there any?
I'd jump in real quick. One was
Please.
just a big fat bias from our point of view here would be hospice is a wonderful alternative. So when appropriate, and from my bias would be, perhaps ours would be, as soon as one qualifies for hospice, and we've talked about that in other webinars, hospice is generally a very good idea. And for one of those reasons, it's because you have someone to call 24 hours a day, and in so many ways, it can help you avoid the ER. So that's one answer, but you may not be ready for hospice for one reason or another, so that may be out of reach. But that's at least one answer to the generic question.
Yeah. I'm sure this is already happening, but having an action plan, a symptom action plan, is super helpful. So am I green today? Am I green? Am I yellow? Am I red? And having sort of a when you're in the green and the yellow, using what's available to you in your home. When you're red, like, are there any steps before having to go to the ED? I think it is really helpful. I will say there are bridge to hospice programs depending on where you're located. So palliative care programs in the home, advanced illness management programs exist as well. I think that is a really great conversation to have with palliative care provider or your pulmonologist about what is available if hospice is if you're not ready for hospice yet. Of course, geography is a big issue there. Insurance coverage is a big issue there. And so we'd have to know more about that, but there are things that are available. But right now, it's empowering to have a symptom action plan because you know exactly, like, I get to pick the color, right? I get to say, am I green? Am I yellow? Am I red? Or whatever it is. Am I ready for the ED? Am I not ready for the ED? But it's just also like a great mental exercise of like just getting yourself ready for all the symptoms and how you manage them, and just that can help a lot of the anxiety. Go ahead, BJ.
No, nothing more to add there. Yeah.
Okay, we have a quick question, then we'll go to the hand. Tracy asked, what is the role of a hospitalist?
Great question. You want to do that, BJ?
Oh, sure. Well, hospitalist is a relatively new field. Most hospitalists are internal medicine physicians. So it's sort of In the old days, you're a primary care doctor when everyone had a family practice or a primary care doc in the community. Oftentimes, those doctors would have privileges in the local hospital and would follow you into the hospital if you needed to be there. That old way of being got disrupted in the 90s when hospitalists were born. And it was proven that hospitalists generally did a better job of managing care in the hospital. It's sort of internal medicine focused in the acute care setting. So it's a relatively new phenomenon, and it's got its problems. I think a lot of us would love to have our regular doctor out in the community be our doctor in the hospital, and there's really something to be said for that. That is just harder and harder to do. Most hospitals are staffed by hospitalists now, and so they have shift work. They're your doctor for the 5 days or 1 week that they're on, and then they go off and a new hospitalist takes over. So it can feel very disjointed. But the upshot of a hospitalist running the show in the hospital is they're very, very, very familiar with the hospital. And again, as we're saying, it's its own it's its own world within a world there. So a lot of primary care doctors in the community no longer would be even able to navigate the hospital, even if they had privileges very well.
Yeah. And they're efficient. So their job is to make sure that they're covering that they're running with that ER differential diagnosis and continuing to investigate and making sure that you get the right test at the right time. And yeah, it's communication with the primary doctor is I think where you can self-advocate, like, this is my primary doctor's number. Can you make sure my information gets faxed to them? Can you get a hold of my primary care doctor about X, Y, and Z? And if you have an advocate, a family member that can help, hey, at 5 o'clock today, when do you have bandwidth to talk to somebody? At 5 o'clock today, we can do a conference call to speak with a primary doctor so we can, you can endorse this information so they can run with the diagnosis or whatever workup you were doing once I'm discharged. I think keep in mind that hospitals are also, like the ER folks, they have like 30, 40 patients in their roster on a daily basis. And so anything you can do to kind of get some of the hurdles out of the way for communication, they'll love, because they want to have those conversations. It's just really intense. Time management. Sorry.
Hey, no. Joan, you've had your hand up. Thank you so much. You may have to unmute yourself on your end.
Thanks.
Hi, Joan.
Hi. First, I want to say this is a great topic, navigating the ER. This is the first time I've ever attended a webinar on this topic, so it's really good to know what to expect when you go to the ER, when to go, your action plan, and all of that. I do want to make a comment because earlier someone had mentioned about her dad going into the hospital and the mom having a bad experience at the hospital before, and the mom was with the dad. Anywhere there is an organization called Aging Life Care Association, which they're private pay nurses and social workers that do care management in the community, and it's a national organization. So I just wanted to mention that. But I do want to say I do advanced care planning in the community. And so I wanted to know and I know you kind of touched on this as your last comment before you took the questions, but what kind of panic is there if an elderly patient does not bring their advance directive to the emergency room?
Did you say, Joan, I'm sorry, did you say what kind of panic?
Yeah, yes, panic. When I say panic, I mean for the healthcare, for the physician in the emergency room taking care of a critical elderly person. Is it advisable for them to bring their advance directive with them to the emergency room, or is it really not needed at that point?
Joan, I just want to say thank you for the work you do. Advanced care planning is so, so important. It helps everybody, whether in the outpatient setting, inpatient setting, certainly in the emergency department. Understanding people's wishes is super helpful in the emergency department. rather than doing things that are invasive and time consuming and maybe not super helpful. If I understand that somebody wants to be comfortable or have limited medical interventions, or they want it to allow for a natural death, then I can really focus the environment that they're in, the interventions that we do on those things. In general, as we mentioned earlier, and Joan, again, thank you for bringing this up, while many of us will ask a few questions about, does CPR make sense at this point for you? A lot of times people may not be able to have that conversation with us. And we want to do things that make sense, but by and large, if you present to the emergency room, we will do interventions to make sure your heart's beating and you're getting oxygen in your body. And that usually means invasive medical procedures. Without necessarily the other step, which is really having a conversation about quality of life, or will this make somebody's life better? Meaning, and quality of life, the way we all see it, like being pain-free, being comfortable, being able to move my body and do the things that bring me joy. Or how long will this give somebody? If I do this, then they'll live for another 10 years. That's not often something that we discuss. And so, yes, please bring your your advanced care plan, your out of hospital DNR, depending on which state you're in.
Okay, thanks.
Thank you, Joan.
Thank you, Joan. Yes, thank you, Joan. Where are you in practice, by the way, Joan? You still on there?
I'm actually in St. Louis, and I am an end-of-life doula, but I have done my training, my advanced care planning training with Respecting Choices, Vital Talk, and CAPSI. So, and I've done actually the American Bar Association's advanced care planning training.
Well, thank you for all the work you do.
And honestly, I knew how important it was, or it is, for people to bring their advance directive with them to the hospital. But I've always wondered, what is the worst thing the emergency room physician has witnessed when there has not been an advance directive for the patient that they're taking care of? I've always wondered how horrific that might be, or is it even horrific?
It's subjective, right? I think I have engaged in procedures that
I got that. Thank you.
I think sometimes we do things because it's the way that things are, but you don't always feel that you're honoring the person in front of you. And it's a system issue. It's not a person's fault. It's not, it's just a systems problem. It's a cultural problem, right? And so, yes, often the moral injury of having to do things that are probably not honoring the person in front of you, but the system is not forcing it, but leading for it to happen is really, really difficult. And not so much for us, but because we don't want to create suffering, right? We went into medicine because we want to make things better for people, and we want to honor a person's personhood. So yeah, sorry about that. It's just heavy.
Thank you.
Thank you, Joan, and thank you, Claritza. And I really appreciate you sharing that tenderness in that answer. Yeah.
Yeah. Got another question. Are
Doctors
you
have
two okay to go a
feelings
little
too.
bit more?
Yeah.
Okay.
Yeah, I am, Claritza.
Okay.
Yeah.
And I echo BJ. Thank you, Claritza. So way before DNR, advanced care, end of life decisions, is there a legal way to allow a designee to get ER medical information about a patient with the patient's approval? What is possible without that approval? So maybe just the question is, can you just call and say, I need information on this patient, and you're not designated as a proxy in any paperwork? You just say, I'm this person's daughter, I'm their spouse. How does that look without documentation?
That's a tough one. Depending on your facility or the hospital, and depending who picks up the phone, people have different understanding of what the HIPAA law is and what it stands and you know what is acceptable and not acceptable. What I will say is that as much as possible, making sure that you are on the list of people that can get medical information is really helpful, so that when there is somebody to update, that they know who to call is very, very important. If your loved one is able to advocate for themselves, even if it's just to say, call my daughter, making sure that there is that dad or mom have a card or something where they can give it to the provider or the nurse, the triage people, and say, this is my person that I want to make sure is well informed on what's going on. And then remember, we love having the advocates, right? And so just making that as easy as possible. So when you call the emergency department, you can say, you know, I'm so-and-so, I'm so-and-so's daughter. I know that y'all are busy, but I am, if you guys need any information on my mom or would love an update, then they can call you back after they check in with your family member. I think by and large, we love communicating. It might not be at the pace or the timing that you want, right? Because the emergency department is really busy, but everything and anything you can do to set that up ahead of time is really, really helpful. We also want to follow the law and make sure the HIPAA law exists for a reason. And so we certainly want to make sure that we're doing that legally. BJ, you wanted to say something? No.
Can I add a question to clarify what you just said, Claritza? So let's say my dad, who is not living with anything serious or chronic, has a stroke, goes into the hospital. I travel there to see him, and he is not with it enough to say, this is my daughter. If I just go into the hospital then and say, this is my dad, I'd like to see him, is there going to be any process of vetting that or checking that, or in general, when someone says, hi, this is my person, I'd like to be updated?
Yeah, I mean, I think we err on the side of, our due diligence, right? Of, tell us about, we try to gather information on what's your relationship with this person, et cetera. Try to validate, that relationship and how it exists. But if you are, showing up for the most part, and you are showing that you come in good faith and that and you're present after the due diligence, which probably, again, depending who you run into, may not be as strict. For the most part, we engage in conversation with folks. Now, in terms of making medical decisions, there may be some more digging about documentation, et cetera, but updating, et cetera, I think for the most part, if you're showing up in a hospital room and that initial discovery is acceptable, then for the most part,
yeah, great. I love this question, Tracy, and I feel like you both will as well. What, on empathy, what can a patient do to help the doctors, nurses, and staff during their ER visit?
Well, I think that question kind of gets right at it. You can kind of keep an eye out, knowing this is a team sport and you can kind of extend the benefit of doubt that everyone is trying to do difficult things with what resources they have. And so sort of just daring to kind of consider the rest of the people in this mix, even while you or someone you love is really struggling, is kind and important, and also probably might get you better care on some level. Part of what happens, human beings being human beings, and while for all our talk about triage being a relatively objective medical science, it's also true that these are people. So if person in room 2 just is only screaming at the doctor and telling them everything they're not doing, et cetera, it's probably likely that the doctors or nurses or whatever else are not want to go in that room. You know, so things like this, and I don't want to put too fine a point on that. It's not your job as a patient to somehow tend to the feelings of the people around you, but as a human being, I think we all know that that generally gets you farther in this world. So I'm not sure that that's an answer to your question, but I love that you're even asking that question. And perhaps the webinar includes his comments that they can help us understand what's going on the other side of the equation. So just so you have some basic understanding and some empathy to exercise, so you know why what's happening is happening.
Yeah. Yeah. Don't be mean to the nurses. Don't be mean to the patient care associates or PCTs, patient care techs, or it's a new term for what I guess the old term was orderly. Those folks don't make, especially the PCAs and PCTs, they don't make that much money, and they bust their butts. Please be kind to them. The nurses and doctors, we can take it, but certainly the doctors, we can take it, but those folks are they're the best thing, you know, they're everything, and they really help get the ER running. And so be very, very, yes, Wendy Lau was my resident. Oh my God, you're recommending her book. Wendy Lau was not my resident. She was a resident when I was oh my God, Karen, thank you for talking about Wendy. She's the best. Anyway, where was I? Be kind to folks, please and thank you. I know you're busy, and not I know you're busy, but I know you're busy and validating and at the same time asking for stuff. And yeah, Wendy did residency, one of the toughest, best residencies in Brooklyn, and so she knows all about this. So yeah, that's a good book. It's called The Inner Practice of Medicine. Karen, thank you so much for sharing that. Yeah, ER people are people. That's I love that you said that, BJ. So yeah.
I think we got through all of our questions and comments. I just wanted to read one note from Deb, who said, I want to mention that some things can be handled at urgent care facilities instead of the ER. They might have longer hours, and if you can't see your doctor right away and need help before an appointment is available, you may be able to get help there. So that's just a shout out from someone who's been there. Thank you so much, everyone, for being here. Thank you, Claritza, BJ, who's wonderfully helpful information. Thank you so much.
Love
Thank
you
you,
guys. Have a good
Claritza.
one. Thank
We love
you.
you too.
Happy
Thank you
weekends
very
all.
much.
Thank you. Talk to
Bye,
you soon.
everybody.
Thank y'all. Take care.